So details aren't available in this case, but I think an important point has been raised that comorbidities matter in CML. It matters in initial treatment choice to perhaps minimize the risk of complications, but still maximize chances of response and benefit from therapy. When we get to the point of resistance or a more difficult setting, comorbidities may seem less important because the disease may be driving us or pointing us towards only one choice or specific treatment choices. But we just have to learn how to manage that risk and balance that risk, the benefit of treatment and the benefit of the proper treatment versus what the potential risks may be. In the case of ponatinib, we have questions about vascular occlusive disease and cardiovascular risk. With other agents, we have concern about metabolic changes, also vascular disease risk, and other problems. So, for the case of ponatinib, I think knowing the patient's cardiovascular risk status, their cardiovascular risk can be calculated quite easily, much like the risk assessment in CML. A Framingham score or a European scoring system is also available that tells you what a patient's likely chance of a vascular event is, and that can be managed. Clearly, we need to know what comorbidities exist. Does the patient have hypertension? Do they have coronary disease? Do they have other vascular disease? And manage that risk. Hyperlipidemia as well. So I think we probably have been under-managing the comorbidities of CML patients and been focusing on their disease. But in the case of both initial treatment and the treatment of resistant disease, particularly with medications like ponatinib, it's important to know the whole spectrum, identify what should be treated anyway, irrespective of what medication they're on, and then perhaps focus a bit on what can maximally manage the risk of a TKI while patients can still derive benefit and get good response, like in this case. In this case, we see the patient had a dose reduction due to toxicity early on from 45 milligrams to 30 milligrams. We've clearly learned from studies of ponatinib in looking backwards, and we have current trials looking forward, that initial and subsequent dosing may not need to be the same. At the current time, 45 milligrams still is the recommended starting dose in the US, but there is instruction that if a patient achieves response, that dose should be lowered. Once a patient achieves a categorical improvement, a cytogenetic response, if a patient has a lesser degree of relapse, perhaps they still have cytogenetic response, we may want to wait until they achieve a molecular response, and that's just my opinion. But overall, the party line would be to consider and really to execute a dose reduction once a patient has begun to respond nicely to ponatinib to lower the risk of complications from 45 to 15 milligrams, or if in this case the patient had been on 30 milligrams, we could consider reducing the dose to 15 as well, especially given her very nice molecular response. Again, studies are continuing to help us understand the long-term outcome for patients who have those strategies deployed, either starting at a lower dose, and clearly the question about dose reduction after response. So we should stay tuned for those, but those are the current recommendations. So the take-home message for this case, I think, would be that although patients can do very well in the beginning, we have to pay attention to their risk. This was a higher risk patient by risk stratification from the get-go, and while they did well initially, resistance and relapse may be possible. And while it's an uncomfortable and a difficult situation, the proper testing can really inform us, give us the path, and in this case, identifying a T315I mutation led us to the right drug, which was ponatinib. And if we are careful and knowledgeable about risks versus benefits, we can salvage patients effectively, use the right therapy, and manage any risks or any complications that emerge, and still have good outcomes in CML, even in the case of resistance.